Do you want to comment real quick about just the imaging work you're doing that ASAP's supporting? Just a quick synopsis of, because we just talked about some of the amplified MR.
Yeah, so really quick, I'll give an update. So at last year's meeting, I met he's a mechanical engineer by training at the ASAP conference who independently was attending. And he does a lot of work looking at mathematical modeling of cerebrospinal fluid at the craniocervical junction and within syrinx cavities. So what we're going to do in partnership with ASAP is actually validate some of his mathematical models using patient data that'll be obtained with MR imaging with some cardiac gating as well. So really exciting stuff, and our hope is eventually we'll be able to look at static MRI imaging and use his mathematical modeling to calculate flow velocity and changes in flow velocity before and after surgery and correlate that with patient outcomes. So really exciting, and it's a 100% ASAP connection. So really thankful for that.
Well, congratulations. It's exciting to see that, and we'll look forward to hearing about the work, next year. So questions in the group? I know you still got a little bit left in you. Almost there. There is a reception at the end. Here we go.
I have a question for Dr. Bramall and for Dr. Moss. Dr. Bramall, would you, or I guess what are your thoughts, or do you agree or disagree, for the looking for swelling in the optic nerve, is it okay to just get the simple answer when you go to a regular eye doctor? You do your exam. Do you feel okay? They tell you, I'm going to dilate your eyes and I can see your optic nerve. Do you feel like that's 100% accurate, or, your thoughts on that? And then Dr. Moss, I'm just curious if you have any concerns of AI, and just if you could talk a little bit about that.
The risks of AI, yeah.
Yes.
Okay. Dr. Bramall? Are
So
the eyes the window of the brain?
So I would definitely say, and just in my experience, that I prefer, patient to see a dedicated neuro-ophthalmological provider. The reason for that is, for example, if you look at something like Friesen scale, if you take like 100 ophthalmologists and you ask them what the Friesen scale is on the same picture, they're going to give you different answers. And so a lot of the time, especially like even after being assessed by a specific neuro-ophthalmologist, having consistency, I think, is really critical. And so there's been, patients that have come to my clinic where they've been seeing the same ophthalmological provider, even though that person may not have been a neuro-ophthalmologist, but they've seen that person for the past 10 years. And so in that situation, I'll say, okay, makes sense. Go back to the same person that you've seen because that person knows you well. And so they'll be able to detect differences, in the optic nerve that somebody who's meeting that patient for the first time may not notice. And so those are the situations where I would say it's okay to go to a provider, and especially if they know you very well. But outside of that, whenever I get somebody, a new patient that comes to clinic, I always recommend going to a dedicated neuro-ophthalmological provider. And another reason for that is that there's a bunch of entities that actually look like papilledema. So there's a whole bunch of things that fall into the category of pseudopapilledema. And sometimes if you're not a dedicated provider in that area, it may be difficult to differentiate between what is real papilledema and what is pseudopapilledema.
And the issue that you could have high pressure and not see it in the eyes. How often do you see that?
It's possible. We see it all the time. When we get lumbar punctures for patients, we see, and I did comment also on the fact that a lot of the time we actually see unilateral papilledema. Mm-hmm. But, again, that, range of CSF pressures, anywhere from 15 to 35. In general, the higher the pressure, the greater the likelihood that there's going to be papilledema. But then, of course, everybody is different in terms of their anatomy. So everybody, has a different kind of cutoff point. For some people, they may develop papilledema and they only need a pressure of 25. Other people might require a pressure of 40. So that's the thing. Everybody's very different, right? So we're all just kind of gravitating to the mean. And there's going to be variations between patients. So.
Yeah, good point. We're also told once you drop the pressure down, don't expect the papilledema to go away overnight. It actually takes weeks.
Yeah, it'll take a bit. Sometimes we can see changes pretty quickly, but yeah, at least a week.
Was there a second part to your question with AI?
Yeah.
Are we at risk with AI and robots taking over the world?
Right. That's an excellent question. Concerns of AI. Well, I guess there are so many aspects that might in AI that might worry us, especially patients. For example, issues such as privacy and confidentiality. So this is an important topic for, all of us to remember and to be aware of. And so nowadays, there's actually a huge push in legislations towards what type of data can be used in training different AI algorithms and how patients or individuals should be informed when their health data is being used in different technologies. And I feel that another interesting point that I wanted to make is about the transparency or the interpretability of many AI technologies, because I feel that even for a lot of us and many patients, people tend to think that AI is a black box, and nobody really knows what's exactly going on inside the box. So I believe that with more training data and with more testing, we'll be able to improve the interpretability and transparency of many AI models. And actually nowadays, most AI technologies are open source, meaning that anyone can go to the internet to look at their computer program or computer code and hopefully to be able to reproduce that and explain that. But I think these are all very important considerations for us.
Scary to think about, for sure. At our meetings, it was frightening for us to hear, that the folks that are doing the modeling for AI to basically look at intelligence and, they can go far beyond what we can, right? Because they can pull in all sources that ever exist that we can't do. But there's certain things, of course, they cannot do, right? That would be obvious and human. But I guess they're up to about a 12-year-old, we heard, that they know the knowledge up to a 12-year-old, and about another year and a half, they'll have the entire potential intelligence of human their whole life. That there's no way you could beat it, sort of thing. It's really fascinating how fast this is moving. This is our era right now for AI. It's really fascinating.
I just want to add to that. I know there's a comment in the back. It's important that there's checks and balances. I think, Dr. Grant, you may have even reviewed this study in pediatric neurosurgery. There was an AI model created to look at predicting success after endoscopic third ventriculostomy against a well-published score, and that was, a logistic regression model, just the way we do a lot of our studies. And the human model, won. And it wasn't by a small margin. So AI is not always better, is my point. Yep. And I think we need to keep evaluating and reiterating things as time goes on. And certain things, yes, they can do millions of computations, but we need to check and not just take it as gospel too.
Great point. Dr. Gray.
Hi. So 2 questions. So first of all, the point about papilledema and pressures and things like that. I know I took care of a patient who had an opening pressure of greater than 55 centimeters of water, who got admitted to the hospital. 2 ophthalmologic exams, no papilledema, right? So I don't think, it seems like the ophthalmologists have commandeered high pressure, and it's all defined in terms of the optic nerves, but high pressure can affect many nerves, not just the eye. So I think I don't know. I just think it's not right to just have papilledema as the only marker. So that would be my one comment. And then the question is do you think, Dr. Zhao, you can make the CSF flow studies look any better than they do now with what you've got going on? Because I think in general they kind of suck. If you could make them look better, because, with that motion and everything, looks fantastic. And I bet you our CSF flow studies could look so much better with that imaging. Be great. Thank you.
Any comment?
I was going to say, yeah. I mean, we've had patients with abducens nerve palsies that don't have papilledema. So it's certainly the case.
Dr. Gray, just to follow up, I thought we had some patients who were extremely low pressure, with clear leaking that had papilledema. Did we ever see, because there was some,
I don't know.
because we always interpret as high, but there were some that there's some exceptions where we see changes in the eyes with low pressure. It's very hard to interpret. Have you ever, does that ring a bell?
I have not. I don't remember that,
Maybe it was
Jerry,
at Stanford. Yeah.
Yeah, I don't remember that.
But it's fascinating. Sorry. Who's up?
Maybe let me just make a small remark about the quality of the image. I absolutely love this conference because this really pushed me to work harder. And obviously, we always welcome challenges like this. And actually, what we found was that a lot of speakers actually mentioned this, that the position of the patient during the scan can actually sometimes affect the amplified motion that we process. Therefore, we are actually looking to optimize a position for patients so that we can get consistent results after amplification. And another interesting aspect that I would like to highlight is all these other confounding factors that may affect CSF flow or even blood flow. For example, we recently did a systematic review on pediatric brain blood flow using imaging technologies. And we found that actually coffee is a vessel restrictor, meaning that if you had coffee during lunch, it's very likely that your blood flow in the brain can be as low as like 30% lower than before lunch. So we really have to consider things like this and inform our patients before their imaging studies, for example, not to drink coffee about 6 hours before the scan, and many other confounding factors that we need to take into account in order to obtain reproducible and consistent results.
Good thought.
Okay, I love hearing all that. Well, maybe not the coffee comment, but I'm very interested in having exactly what ASAP stands for in my mind, which is, having more meta-analyses, bigger sample populations, those, comorbidities, circles of different types of connective tissue or other problems coming together. So I in my mind, AI is very exciting for me on that because there's a lot more you can do statistically and just finding those connections. So if you could speak to that at all. But then I also have more questions on for Dr. Bramall, that you called it a TVOS, transient visual.
Yeah, transient visual obscuration.
Yes. How would one tell the difference between that and like an overstimulate, like I have convergence insufficiency, right? And I have a neuro-ophthalmologist that I works for, yeah. But I've also had it explained that sometimes if you're just kind of having your system overwhelmed, you will kind of check out, and then having orthostatic issues. So how do you go about that? And for your IRBs, do you work with people that have already had surgeries, have already been shunted?
So to address the first question, for TVOs, that's a very good point, actually. I think a lot of kind of like vasovagal episodes, for example, could be potentially interpreted as TVOs. The way that the classical description is that it's kind of like a black curtain, and I think of that, we learn about that with respect to things like retinal detachment, but it's something that's a lot more transient. The other thing that I would say that characterizes it, and again, you could, are the provocative maneuvers, but again, some of those provocative maneuvers may actually also have a similar effect. But the things like anything that increases intracranial pressure typically will provoke it. So that's another way that you can kind of differentiate between the two, but it's, yeah.
Could it ever just be on one side? Like the same side consistently?
Technically, if you think about how intracranial pressure works, it's quite possible for it to be unilateral or bilateral. I mean, you can imagine that you would have elevated pressure on one side, like we were just talking about papilledema on one side, but not the other side. So you can have, unilateral elevated pressure. Most of the time it's going to be bilateral, but it's certainly, feasible to imagine that you would have a situation where it could be unilateral. And then your second question with respect to IRBs, unfortunately if you're referring to the trial that we're doing at Duke, we have kind of limited it to patients who haven't had any prior interventions, unfortunately. Yeah. A lot of patients do already have shunts, and at some point, of course, it would be great to actually incorporate those patients. My hope is that if we can at least prove that the drug is efficacious, we can actually get insurance companies to cover it for a lot of these patients. And so we can just cover it for that particular diagnosis of IH. So currently we're not actually enrolling patients that have had either venous sinus stenting or shunts or even optic nerve sheath fenestration. But hopefully in the future, if we do get positive outcomes with the trial, then we can actually apply that to patients who have had interventions in the past as well.
Okay. Great. Last question in the back. Yes.
Hang on.
I'm sorry, I can't hear you. Just the mic's coming right there.
What does it mean if you dolloped your dura? I had cord, tethered cord surgery. And 4 or 5 days later, they took me back to surgery because they said I dolloped my dura, and that's what's on the surgical thing that went into insurance. And then it said in the brain, but I was told that they when they numbered it, the only number they could get paid back by, this was the hospital, was that they had to leave it saying that it was in the brain, but it was in my back. So what's it mean?
Dr. Heiss, that ring a bell to you? Doll?
Yeah.
Vijay, anything?
Paola Bolognese. Dr. Paola Bolognese.
Interesting. I'm happy to look at it, but I don't know an easy answer there. So.
But I'm finding that a lot of things are so much more explained from back then. That was 2007. And it's amazing the difference in how you can explain all these factors.
True.
Yeah.
No, thanks for your question. It gives us homework to do.